All right, so as usual, we are recording this session. So thanks for joining us this morning. Today we're going to cover off the patient medical home practice assessment tool. So just a couple of housekeeping pieces before we get started. Just please keep yourself on mute, keep background noise to a minimum, and we will share the recording of the session with the other supporting documents as soon as it is available. All right. So what's our plan of attack for today? So we started out back in August with the panel assessment and cleanup tool. And based on what we learned about the process, the next steps, and the supports needed, we're working with some of the vendors to develop and pilot dashboards and canned reports. So coming for IntraHealth and the two TELUS platforms, so MedAccess and Wolf. These are in process, and they're going to start to move to schedule sort of an overview session and some more in-depth training, probably at the overview early in December. And I think we'll look to train possibly through December, but maybe into January, depending on how holidays and availability is rolling out. So when we start rolling with these, we're going to consider them PDSA number 2 for the panel assessment and cleanup tool. And then a couple weeks ago, more than a couple weeks ago, we rolled out the EMR functionality. So if we have time at today's session, we'll take some of that time and have some open discussion questions, either of those. Find out you to put yourself on mute, please. Aren't overly exciting, not sexy, they're not fun.
Yes, I'm not hearing you correctly.
Is someone asking a question?
It's really hard to hear you. There's a lot of background sound.
Okay, can everybody just make sure they're on mute, please? Thank you. Okay. So as I was saying, the first two tools, can you guys hear me okay now?
Yes.
Thank you. Okay. All right, so as I mentioned, so we did the EMR functionality tool second, and if we have time at the end of today's session, we'll open that up for some discussion and some questions for that. And so, as I was saying, those first two tools aren't very exciting. You know, there's not a whole lot of drive towards necessarily doing that work. It's not fun, it's not sexy, but it's really necessary as foundational work to support the implementation of the patient medical home across the process and drive towards an integrated system of care. So the tool that I know everyone's been waiting for is what we're going to cover today. So that's the PMH practice assessment. And Lucas Parker, who some of you probably know from working on updating the module evaluations or any other evaluation work, has done a ton of work to pull together the different sort of practice assessments that are out there and tools that have been validated and used in other areas, and to really fit that to our context. And has worked very hard gathering some feedback from a few individuals as well to get us to where we are today. So he's going to take us through how the tool was developed, what it looks like, and what sort of feedback we're looking for during this pilot. And the last thing I want to add to that is that the feedback throughout this is really important to how we're developing and evolving the tools through beyond the pilot. So when it comes to the PMH practice assessment, it's important to take a look at sort of, you know, how the questions flow, which questions you think are important, if there's any duplication. And in parallel to this, the GPSC has formed a practice expectations task group, and they're working through the patient medical home attributes and further defining what it means for a practice to really be a patient medical home. So, for example, they're getting sort of more into the nitty-gritty. So when we look at access, what does access really mean? So there's an expectation that there is 24/7 access to care in that community. It doesn't necessarily mean that the practice itself provides 24/7 care, but it does mean that the patient can expect this in the community, and the practice needs to know where the patient can receive care outside of clinic hours and communicate that to the patient. So last but not least, throughout this process, throughout this webinar, we'll talk about the process and the compensation for doctors and MOAs during the pilot. So with that, I'm going to turn it over to Lucas.
Good morning, everyone. This is Lucas Parker. I know many of you, have worked with many of you before, and I'm excited to be on the line with you this morning. I'm with the evaluation team that works to support GPSC, and I've been helping the PSP team with the development of this tool. And I've had a lot of help with that, so there's been a lot of input from the staff here at the department, and I'll talk about some of the physicians that we've had the opportunity to consult with along the way, and also a special thanks to Joan from the Fraser Health team as well. Joan and I kind of looked at a lot of this material early on together, and she was a real fellow nerd in getting excited about some of the measurement stuff. So thank you, Joan, for kind of helping get this started. And I think too, I'll just mention up front and then throughout as we go through the tool. I'm particularly excited about the fact that we have the opportunity to do a real piece of piloting with the tool right now. Having the opportunity to sort of do some of this field testing before the tool is finalized, and as Aaliyah mentioned, there's this GPSC practice expectations working group that's going to be weighing in on the tool as well over time. So that's an important piece of context. It's just that it's not finalized. There's still going to be a lot of tweaking and updating. And so I think that's important in terms of taking this out into the field, is just that the phase we're at is very much about getting feedback so that as the tool evolves iteratively, it can be made more relevant and more meaningful and more useful to PSP and physicians as well. So I think at a high level, the tool is about stimulating discussion about what is a patient medical home and where a physician or a practice is at relative to the attributes of a patient medical home. So at a practice level, the tool is designed to help physicians understand their strengths and areas for improvement, and to begin a conversation about identifying supports. So I think the point there is it's not about assessment as an end in itself. It's about stimulating discussion within the practice and with PSP. The overall features of the tool, there's about 40 questions, and they're organized by the 12 attributes. So there's a number of questions per attribute. And the way that the questions are organized by attribute is somewhat arbitrary. So I think that'll become clear as we look at some of the examples. But so questions about, say, referrals, those questions could be placed under comprehensive care. They can often relate to team-based care, or even access or GP networks. And I think the point is not to be super picky about where they're categorized. I think a lot of these concepts sort of span across a number of attributes, and so they're ordered in a way that seem to make sense so far to the people who have reviewed them. But we recognize that they could a lot of the concepts could live under a number of the attributes. And just so we can have the attributes kind of top of mind as we look at the tool, I've included the visual representation of the patient medical home model, and with the attributes broken down into the three categories: the service attributes, relational enablers of care, and structural enablers of care. So if we need to, we can pop back to this slide just to clarify our thinking. Okay, so in terms of how the tool was developed and how it got to where it is now, basically we went through a process of pulling together a bunch of existing patient medical home measurement or assessment tools, weeding out the ones that either weren't validated or didn't seem to align to the concept of the patient medical home that's being used in BC. We then sort of combed through that whole bank of questions from previously developed tools to look for any gaps that where areas that are being referenced a lot in BC aren't addressed by questions that already exist, and wrote a number of new questions to fill in those gaps. And that sort of produced a big, what I was calling the kitchen sink version. So it was a very long document with a ton of different questions. And then, so we took that long version and ran it by a number of our colleagues. So that included some of the staff here in the department, some of the doctors and representatives on GPSC, as well as division representatives. And that process sort of helped us to pare down the tool by about 50% and focus on the concepts that people felt were the most important, and also to refine the language a little bit. I think one challenge was that a lot of the questions were based on tools that were either developed for use in Alberta or the United States, and where I think there tend to be a lot more kind of larger group practices. So some of the questions had to be tweaked to kind of fit a more solo practice type setting. So that review got us to a pared down version, which is basically where we are now, and so I get where we are now is the piloting phase, and I think that's a good place to be. I think it's great to have the opportunity to get broad feedback from the field before we finalize something, and I guess the point there is just to again reiterate, the tool is not perfect. It still needs to be tweaked. We're actually aware of some potential shortcomings already, so we've been talking with a number of rural physicians about how the tool could potentially be made more relevant in rural settings, and those conversations will be continuing alongside or in parallel with this piloting phase, so that as we get to a finalized version, we can pull in that feedback as well as what you're hearing from implementing out in the field. So again, the point is, at this point in time, physicians are able to help us understand which parts of the tool work well and which don't, and this is about getting feedback. So here I've just got a number of some notes on who sort of helped pare down to this piloting version. So some of the PSQ leadership, GPSC physicians, physicians from rural and remote division, and then we're sort of still looking at options for talking to sort of some clinical advisors, and that's still in the works. And I think that's partly where this piloting feeds in. We need to know if the tool works for physicians broadly practicing throughout the province. So part of getting that feedback, we've provided a bit of structure. So I believe that the tool itself was emailed out to the group last night or this morning at some point. And if you've got it there, you'll see on the second or third page there's some review questions that are there to prompt physicians to keep this sort of these piloting review considerations in mind as they go through the tool. So there's two questions. The first is basically asking for physicians to, as they go through the tool, make note of any confusing or inappropriate language that doesn't fit the context of how they practice or how primary care tends to be organized in BC. And the second is about duplication. So we did start with a lot of questions, and we don't want to have the tool be longer than necessary. So if there seem to be questions that are getting at the same kind of thing or measuring the same thing, we want to hear about that and see where potentially questions could be eliminated. There is a bit of a bias towards wanting to keep the wording of the questions, to change the wording as little as possible, and that's because the tools have been tested and validated in other settings. But with that said, if there's language that really doesn't resonate, then I think it makes more sense to change the language or to remove the question. So we want to hear about that. And in the tool itself, the Word document, there's a space on the right-hand side margin that sort of that asks them to provide any of that feedback as they go through the tool. As far as the questions themselves, there's two broad types of questions that make up the tool. So the first I'm calling introductory questions, and these are taken directly from the college's patient medical home self-assessment. These questions tend to be at a higher level and a more conceptual level, and I'll give an example in a minute. Initially, we hadn't included these questions because they seemed a little bit too high level to be meaningful in terms of providing a basis for thinking about quality improvement. But a strong case was made that they could serve a purpose in communicating to physicians as they go through the tool what these concepts around the patient medical home are. So basically to build understanding of what exactly is a patient medical home. And the hope is that some of these questions may also be able to support evaluation and sort of telling a story over time, because they would facilitate making some statements or higher level claims if we're seeing improvement over time. The second set of questions we're calling quality improvement questions. So these are they're much more detailed in terms of the content in the question and then the response options for physicians to respond. And the hope there is that there's more straightforward interpretation, and I think you'll see why in a minute as we go through some examples. They also are designed to indicate for a respondent or a physician where they're at in terms of the patient medical home attribute, but also where they can think about going in the future. So the hope is that those will be really valuable in supporting quality improvement. So I took timely access as an example. And so the first question here is one of these introductory questions from the college self-assessment. So the question asks physicians about the practice ensures access to provision or direction to needed advice or care 24 hours a day, 7 days a week, 365 days a year, and ask them on a sort of generic scale to indicate where they fall in achieving that. So that's an example of one of the higher level questions. And then taken from one of these more QI-focused tools, this is one of the QI questions around timely access. And this is the format that all of the QI questions take. So on the left-hand side, you've got specification of some aspect of the practice. So in this case, it's the approach to providing same-day access. And then the scale on the right-hand side outlines a continuum of practice patterns. So at the low level, the practice at the level D, responses at that end indicate that the practice has work to do to reach the standards associated with the patient medical model. And then at the high level, level A, the way the practice is organized is already highly indicative of a patient medical home. So the example here at the low level is the approach to providing same-day access relies on referring patients to a walk-in clinic or other care provider. And then at the high level, the approach to providing same-day access relies on systematically implementing a schedule that reserves sufficient appointment slots each day to match patient needs. And there's options in between as well. But so at the high level, you can see that's kind of, it's about implementing some sort of advanced access system. On the next slide here, I've got actually these are the three questions that make up the whole timely access piece of the questionnaire. So you can see how it flows. So the introductory questions is put up front, and the idea is that considering that question will help the physician familiarize themselves with the concept. What are we talking about here with timely access? And then the QI questions follow, getting into that next level of detail and more specific responses. And on the next slide, I've just got another example, so for team-based care. And you can see, so this is basically how each of the sections for each of the attributes is organized. So I'm almost done. I just have one more slide, and then very happy to talk more and answer questions. So just talking about this stage we're at again in terms of piloting the tool, recognizing that it's not by any means perfect. It needs tweaking, and that's sort of the whole point of where we're at. So we're looking for feedback in a few ways. The piloting review questions, so those are the two questions that are provided at the front end of the document for physicians to consider as they go through, and then there's space in the margin for them to make notes and provide that feedback. At the very end of the tool, there's also a space for general comments or suggestions. That's a much more open-ended space. It just sort of provides an additional page where they can provide any more general comments. And then I think that Aaliyah might speak to these next pieces a little bit more, but so there's also sort of the process piece surrounding the tool, and so we're also very interested in hearing about how are these results sort of driving or facilitating conversation around, so how can PSP support? What's the next step in terms of driving towards supports and service offerings from PSP? Kind of general logistical things, how long is this taking? And any other barriers that might come up along the way. And then is there interest in kind of tying the use of this tool to the action planning? So how are those conversations going, and how is the tool being used to then start talking about next steps in terms of PSP support and practice change? So that's it for me. I know Aaliyah has some other really interesting material to go over in terms of compensation and process. But I think we can pause now and just have any questions if anyone has anything they'd like to talk about or ask.
Hi, this is Ryan from Fraser. Can you guys hear me?
Yeah. Hi, Ryan.
Hi. So what my division has kind of said, and what is a big question for me, is what happens if you go through this assessment tool? I mean, if you discover that their challenge is access, then of course we have lots of experience and tools to help them improve their access. But what if, you know, their challenge is, or they discover that, hey, I'm actually ready to implement the patient medical home model, and what I need, I've looked at my panel, and I've done this assessment, and what I need is a really experienced sort of geriatric nurse, because that's my population, and that would take a huge burden off me and increase my capacity. You know, what do we do with that? Because I know that when you look at how the patient medical home and the primary care home, those circles link, it's really about access to those. Well, it gets into team-based care, and that's a big barrier I'm looking at right now, is how do we enable that? Where is that going to come from? And that's what physicians are, in my division, are sort of asking at the outset, is what happens once we figure out that's what we need.
Mm-hmm. Great.
Hey, Ryan, it's Leah. So when you've got somebody who's really ready and is kind of at that point, then that's where, like, that's the intersection of sort of the patient medical home and the primary care home piece, right? So with the access to specialized services and more coming through the health authority. So it's something that I think we're still trying to figure out quite how that's going to work and quite how each of the health authorities are looking at meeting those needs. So I think it's something that needs further discussion, not just with Joan, but probably with those who are kind of heading up the primary care home work through the health authority and thinking about how they're providing access to specialized services like that. If it's something like they've decided they need a nurse practitioner or something like that, then it's going through, like, that's the piece that goes to the ministry, and they're looking at doing those contracts individually with those physicians to fund them to have that nurse in their practice. So it depends on where they're at and what they decide they need, but it's definitely something that we're still sort of feeling our way through.
And Aaliyah, this is Jenny. Can I just add to that?
Yeah, please.
Yeah, so the other piece of it, too, is as a department, so that's like PSP Central as well as the Division Central Office, which now, as you guys all know, have slightly different names. But we are also, as a department, thinking through, and also via other partners that work under GPSC, how we're going to tackle the supports and services we provide along a continuum to the folks who want to implement patient medical home. So it's very much a work in process, and it's even bigger.
You're cutting up a lot.
Excuse me? Hello?
Jenny? I don't know. Did we lose Ryan?
Oh, okay, yeah. I was going to say, so I'll just say the process is even bigger than what PSP is doing itself, and so we, as that unfolds.
No, I'm here. You guys are cutting in and out a lot. I didn't.
Oh, can you guys hear me okay?
Everything is good here. We can hear you well.
Here, it's actually Ryan who's in and out.
Okay, so I'll just say that it's...
Okay,
Oh, dear.
It's all a work in progress, and I'll stop.
Yeah. It's not a great answer, but it's the answer we have right now. Because as we've talked about before, it's all new.
Yeah, sorry guys, I didn't hear anything that you just said. It went in and out. I'm sorry.
Oh,
well,
no.
Yeah, I don't know what I did.
Okay. Ryan, can we touch base after? I'm going to email you after. Okay, other questions?
Sorry, I can't hear what you were saying, guys, so I'll just mute.
It's not just you, Ryan. I have the same thing.
That's kind of weird. I don't know. Okay. Other questions, guys?
Hi, Leah, it's Yogita here. So the kind of feedback PSP Central is looking for is you're looking for physicians to pilot it, the tool, provide comments and suggestions. I'm wondering what is the openness of us having it reviewed by our divisions, because they're the ones that are really focused on the engagement piece for the patient medical home. I'm just thinking, like, if we go out and just review the tool with a physician, but, I mean, divisions have something different in mind. Are you okay with that?
That's a good question. I think, I don't know, it's like
this is a tool that we're endorsing as assessing patient medical home. However, like, and I'm just going to speak for my health authority, my divisions are actively already creating or have created their own assessment tool. One of them is actually waiting to see what we have and how they can add to it, because the questions might not be relevant to what they're trying to do with their patient medical home initiative, right? So I just want to put it out there is there openness to having them also look at it, because we'll be working with them, not so much as they GP, because they're accountable to recruit, engage physicians for the patient medical home. We're there to support them.
Yeah. No, I hear you, Gita. Was that Jenny?
Yeah, but go ahead, Aaliyah. Go.
Oh, you go ahead. It's okay.
Yeah, that's a really good question, Yogita, and it's definitely something that we've been thinking through as the tool was developed, and we know that there's even actually another tool that's been put together out there to sort of assess division-level needs or resourcing, sort of identifying resources that are going to be needed. So we are going to have a conversation again with the Central Division's office to kind of talk about maybe it's not this tool or maybe it's some other version of this tool, but how it is that that information can be collected, because we don't think that this tool as it stands right now makes sense to do at the divisions level, so there's more to come with how we think that's going to unfold.
Okay, so I'm going to question that. If this tool is not what's going to be needed for the division level and we're held accountable to work with our divisions and to be assessing these clinics that are putting their hands up to say, I think I want to be a part of the patient medical home, then I feel like we should be partnering with them and having them lend their eyes on this tool as well, because then where does the value of this tool come in for us if we are having to work with our divisions closely on this? Unless you just want us to go and just work with our regular GPs out in the community to get some feedback, but then where is that going to lend? Because it's not aligning with the bigger initiative.
Yeah, good point. I think, maybe I am speaking too strongly when I say it's not the tool that we're going to use. It's just at this point we've been thinking about it as a way to identify practice level supports and services that are needed, but we know that we have to go higher up. So I wouldn't say it's not possible to use this tool. It's just that we haven't had, or for those conversations with divisions, because we've always thought that this would be a way to like aggregate and collect information, and then we would know from across divisions, getting this information from the GPs, like maybe what the needs were. So by all means, I guess for now, we can use this tool for those conversations, but we are having conversations at CPQI about what's the best way. Is this the tool? Is it another tool? And we just haven't had those just yet. So we've been thinking about this as a practice level kind of dive for now.
So I want to just add something to that, and Lucas wanted to add something as well, is that I think the tools, like I think what the divisions want out of something like this is different from what we want out of something like this. So, you know, this is an in-practice tool. It's about identifying the areas where you're meeting the attributes and where you're not, and what work can we do to help a doctor move towards those attributes. Whereas the divisions are thinking about engagement and getting people into, you know, actually starting to do this work and that sort of thing. So I think we're looking for slightly different things. Yogita, I have seen a little bit of the Vancouver division survey that's come out, but I definitely look at those and I think of that more as just as a survey, like they're really just collecting information, whereas this is a little bit different, and it's a subtle difference, but this is a tool that then, it sounds the same when I say it that way, but it's to support them in their practice to make positive change. And then Lucas wanted to add something about the practice expectations working group.
Hi, Leah. This is Ranjit. I have a question too. Sorry, did I cut someone off?
I'm just going to add one thing to that. So just building off what Jenny was saying, and also, so Aaliyah had mentioned the practice expectations working group earlier, and I think there are a lot of sort of conversations taking place at the same time as this takes shape. I know the practice expectations working group will be weighing in and helping to shape this tool as well to meet some of those other needs associated with the larger initiative. And so these things are happening in parallel, which in a way is sort of not desirable, but in other ways it is, because it's sort of this is a chance for PSP and the physicians it worked with to sort of help shape the tool from a clinical relevance point of view, as it is simultaneously shaped from a sort of larger initiative point of view. So I know it isn't perfect. I just wanted to mention that those other conversations are taking place.
Hi, this is Joe. I'm wondering if we could just change the name to do an improved practice self-assessment, because I mean it is an assessment of practice. It's definitely an improved one from the original one that we've had, and it'll support us to be able to do our work irrespective of whether or not it's you know, whether we're working on it with vision on patient medical home or working with individual physicians. I mean, I don't know if you're out there working on a new practice self-assessment, but this probably is something that would save you time to not have to actually recreate that.
Yeah, Sorry, go ahead.
Sorry, it's Julie. Go ahead, whoever that was. All right, sorry, it's Julie. I'm just wondering if we as the leads could speak to Jenny and Aaliyah, maybe not during this conversation. Just, this may not be the right setting to just talk about maybe some of the concerns, because I do have the same concerns as Yogita, but maybe it'd just be more appropriate to take this offline. Just maybe so that we can talk about where and when this may be appropriate. The question I have, I do have a question though for Lucas. Was this developed with GPs? Like, has this been gone? And I'm sorry, I missed the beginning, so you may have already said this, but was this developed with other GPs?
Good question. Thanks, Julie. So many of the questions are taken from assessments that were designed and tested in other settings. Those were designed with input from GPs. Then when we added questions and sort of chose the ones that we felt were most relevant to BC, we did go through a review process with a small number of GPs, so that included GPs from GPSC as well as a couple of rural physicians to get a rural lens on it. So there's been heavy GP involvement in terms of who's made the decisions about how to shape this and pare it down. But in terms of, and I think right now is where we're at the stage of kind of wanting to get broad GP feedback through this piloting process.
Okay. Thank you.
This is Margie. I really like the tool. I've done lots of practice assessments for physicians in Quesnel, and I've used the Dartmouth model and together with the PSP model and do some in-depth EMR searches and such. I really like how this is laid out, and I think going forward it would be I would love to pilot this, but I would also think it would be good to target physicians who are instrumental in each division to pilot it and give feedback from a division's point of view, how it could be used and maybe modified.
Yeah, thanks, Margie. That's a great point, too. So it seems like this is sounding like kind of a scary thing for some people, and it really shouldn't be. Like, it really is a refreshed version of the PSA. It's a little bit bigger, it's a little longer, it's definitely got a PMH twist on it, but it's not some huge different thing that we're doing, and it's not, it's like we definitely need to think about how we're engaging with divisions with this, but between what the division wants out of it and what we want out of it, because remember you guys, we support doctors on the ground in their practice to provide better patient care. So let's keep that in mind as we think about how we're engaging with divisions as well, because I think when it comes to divisions, we need to put a bit of a different hat on, and it's not as high on the list maybe as what we're doing on the ground supporting doctors. But let's talk about it. So for the leads, let's take it offline and let's have a discussion about it. But that's just, I want to think about it that way.
It's Joan here. I'm wondering, something Marie Hawkins said to me yesterday I found quite helpful in thinking about our work. And she talked about the 3 levels of system change or change that we're talking about: the practice level, the network level, and the community level. And for me, if I were to explain this to a practice or to a division, I would probably reference that and say patient medical home, primary care home, is a system shift that we're hoping to achieve at the practice level, the network level, and the community level. And this particular assessment is at the practice level. So yes, there are network level questions that need to be asked or established, and community level. That's not what this is. Doesn't mean that we don't recognize that there is a need for that. And in fact, answering the questions at the practice level may highlight some gaps that can only be addressed at a network level, and that's okay. So, you know, I actually think that acknowledging that this is only, you know, this is the practice level perspective, and that we're aware that there are other perspectives that will need to be considered is always a good thing. That's all.
That's perfect, Joan. Thank you. So the other thing I want to sort of reiterate and build on that is that this is a starting point, and there are just, you know, there will be more that will grow out of it, but it's not necessarily, like, this tool isn't going to hit all of those points. This tool is a practice level tool. So that was awesome, Joan, and thank you very much for articulating it that way. Other questions? Comments? No? All right. Shall we carry on into compensation? Because we will be compensating for use of the tool during this pilot. All right. So we have sort of 3 options around the compensation. This is going to be a little bit different from what we did with the panel assessment and the EMR functionality. So we have completion of the survey plus follow-up action, including a PSP, RST coordinator, or coach. So the doctor completes the survey. They request some in-practice support from one of you. Together, you create an action plan and provide some ongoing support around the QI work. And if they do that, their compensation is set at 1 hour for their survey completion and up to 3 hours for sort of almost like action period work. That is, so there's that for the GP. There's also that for the MOA. And then the MOA as with the others, is compensated at $20 per hour, whereas the GP is the hours at the current sessional rate. So option 2 is doing the survey and doing some work on their own without any PSP support. So they complete their survey, they create and execute an action plan on their own, and they still get an hour for the survey completion and up to 3 hours for their action plan work. Lastly, they can just do the survey and we'll compensate them an hour at the current sessional rate for doing the survey. So the important piece in there, particularly for you guys, is that the trigger is still the QI work, or sorry, is survey completion and submission of the action plan. So we can do 2 separate sessional forms because there's not necessarily any guarantee that someone will do the QI. I've got a background noise right now. Somebody put themselves on mute. There it is. Everyone has still got a lot of background noise there. There we go. Okay. So the triggers for the sessional form are still completion of the survey and then submission of the action plan. So if you have a doc who does the survey, you can give them the sessional form right after that and they can send it in. And then for the action planning piece, whether it involves you or not, you need to see an action plan that's got a documented attempted change on it, same as the module work.
Hi, this is Joe. So it's basically well, I don't agree with us or without us, it's the same compensation. I kind of think that, you know, there should be some kind of incentive for having our support there. And so you're saying if they fill out an action plan, they'll get paid for up to the 3 hours, but if they, I mean, not necessarily if they complete the action, if they do attest a change or anything, it's just basically for filling out a form and submitting that form that they're going to get paid for the 3 hours. What happens about the actual QI work that they're going to do in practice to actually test the action that they're filling out? What about that?
They are meant to be doing, like, there should be some sort of attempted change on that action plan. So it's not just filling out the action plan and saying, here's my goal, here are the tasks that I'm going to do. Here's my goal, here are the tasks that I'm going to do. Here's what I've done so far and what I've tried out in my practice, and then we can give them the sessional form.
Okay, that makes, that's just not explained here very well.
I can add that in the guidelines when we send them out with the other materials.
What would be the reason for compensation to being the same with or without RST support? Like, why would that be offered, with, like the option of without RST support? I'm just going back to way back when we used to give out the practice self-assessments and pay them whether, you know, just because they told us that they filled it out. That was like in the early days of PSP, and I'm almost feeling like this is similar. A little bit more, they're asked to do a little bit more and show us that they did something, but it's feeling a little similar. So I'm not quite sure why if we're a QI team, why we're actually being potentially opted out of their choice.
So this is Jenny. I can jump in there, and it's not intended to diminish the role of the RST or push you guys out. It's a reality, though, that some docs will be able to fill this out and action plan on their own with their teams. And so we don't want to keep those who do spend that time doing that work, who just haven't accessed an RST, from having access to being fairly compensated as well.
How do we know that there's an action plan and work is happening in order for us to pay them?
You have to see it. So they have to get in touch with one of you. If you're not involved, they still have to get in touch with one of you and say, hey, I did the survey, like you gave me the survey, I did the survey, and here is a copy of my survey, a de-identified copy of their survey. And here's my action plan that I did with my steps and what I've done to make that change. So, you know, we are trusting that they've done what they've said they've done, but they still have to show you that before we're going to give them a sessional form and they're going to get their payment for it.
Yeah, I don't know where that decision came from, but that's setting us up for something else, especially if this is called the Patient Medical Home Practice Assessment Tool, and we're saying that it can be done without us, but as we go into patient medical home, what is the role of PSP if this can be done without us?
Well, you know, if we're going to think about it that way, they can do any QI work without us, technically. But, you know, from the action period work and all of those pieces, we know that they can, some doctors want to do that work on their own. Some know what they're doing, some don't feel like they need the support, and so they want to do that work on their own. And so the confirmation that you have when they've done that work as part of a module is a phone call or an email, right? Whereas others do want to have more support in their clinic and everything. There's how many, like 3,500 family physicians in the province. They're not all going to say, I don't want anybody in my practice, I totally know what I'm doing. Not all going to want us in there either, because everybody is different. But it's a reality of life, I think. You know, we offer a super awesome service that supports doctors to make changes in their practice, but some don't want that, and that's okay. A lot of them do.
This is Liz from Queen Charlotte. An idea that I have is if you make it clear that the physician does touch base with the RST or the coach, and they decide how much support the physician needs from the RST or the coach, then it's still, because the coach is the touch point anyway for the survey and to check sort of the action plan and completion of the work. So just have a little sentence in there about, that the physician and the coach decide how much time they need to work together on the QI project.
Yep. Yep, that's great, Liz. Thank you. And we have, so the other thing too around this is that this isn't just coming out without any communication to sort of the broader audience about what's happening either. There's a comms piece that we're currently working on that's in draft right now that I think we're hoping to send out tomorrow, letting them know that, you know, this is going to be available and sort of what the process is and around compensation and that stuff. So we can be really clear in that as well, what the expectations are around the support pieces and that kind of stuff.
Hi, this is Jo. Do you already have an action plan developed with the questions that you're going to that are going to be asked of the GPs, so that, you know, and does it help them go through the process of QI comfortably and easily, that they can do it themselves?
So the action plan, where is it? There it is. Is the same, right now it's the same template that we're using for the module. So we can run through that. But it's, you know, it's the process, so I'm going to flip back to this one. So when they go through and they do the assessment, they're going to sit down and take a look at what their outcomes are. If they're wanting your support in there, then it's something where you would sit down together and look at it and look at their answers to the questions and say, okay, on this attribute, you were mostly in the Bs. That's not quite ideal. So, you know, what's most important to you here? What do you want to work on? And let's think about that in a stepwise pattern and figure out what are the things that you need to do and who are the team members you need to involve and what do they need to do to get you to a point where you're meeting that attribute or, you know, scoring higher on that continuum and getting to a point where you can say, okay, I'm still not quite there. What are the next steps that I need to take to get to that level?
And then, yeah, I'm just going to add to that too, because for sure we want you guys in this space working with the docs using this tool, and that is really one of the main reasons. Like, we see this as a really great opportunity for an engagement tool to get in there and have those conversations, but we can't preclude doctors who are going to work on this on their own from coming to the table and participating, and it is a little muddy as to how you'll be confident that they're actually making changes or giving the, information back to you. But I think that we live in that space a bit already. And again, I just think that this is really a tool that can help you get in there and have those conversations, maybe even with the doctors you haven't yet had an opportunity to connect with.
Thanks, Jenny. Okay. All right, so we talked a little bit about the action planning. So I'm going to back up a little bit, just sort of into the pilot and sort of the expectations around like a data collection piece and thinking about it from that lens. So for the pilot right now, we are going to be paper-based. So I did send around a copy of the tool yesterday. I'll include it again when we send around the materials from today's session, including the recording. But that's what we can use for this pilot piece. So the expectation for that is that they're going to keep a copy of that in their clinic. And then there's also going to be a copy with no identifying information. So the tool itself doesn't contain, like, there's no place to put the name, the address, the clinic name, like nothing like that in the tool. So an anonymous copy can be scanned and should be sent into PSP Central at the psp@doctorsofbc.ca address. And we're going to hang on to those, and they're going to help us a little bit with just sort of seeing where they're at, and also having that feedback on the side of what they think can be changed. So we'll take that in-house and use that to help us evolve the tool as we go through this pilot phase. So the expectation is then that GPs who are interested in doing this work through this prototyping with us are going to reach out to the regional teams. If they come through PSP Central, we'll just direct them to you, and you can provide them with the tool. You can email it to them. You can go into their office and hand it to them and say, let's sit down and do this together. Whatever approach is going to work best with that physician. Obviously, we would want to start with doing that sort of in practice with them, but depending on what they want to do. And then you would sort of move into the, touch base after they've completed it, or if you sit with them and they complete it, you can hand them the sessional forms then, and they can submit that, and then the follow-up pieces. So as I said before, there's not a scoring algorithm in the tool yet. Once we get it into a electronic format, I definitely want to have something where it just sort of spits out at the end what your scores are and sort of highlights areas that they might want to work on. But it'll be more of a process of going through, like I said, and looking at it, thinking about what's important to that doctor and what they want to work on, and working through a step-by-step action plan to work with them to meet that attribute or meet their goal around that attribute. So it should also help us, like looking at some of the questions should also help you direct them to certain PSP services. The new small group learning sessions when they roll out, any of the modules, that sort of thing. Okay. And we've already seen the action plan. Does anybody have any questions about that?
Hi, this is Margie. I've tested the template for the action plan.
Yeah.
And I found it a little bit like the physicians are not really using the one where you have it divided into pre-work and action planning.
Okay.
they tend to use the tasks and the successes and that a little bit more. And actually they tended to write it in the pre-work area, just exactly which ones they wanted, what exactly they wanted to do and by when. So that that middle section it was kind of confusing to them, the pre-work and the action planning, and I don't know, they tend to really simplify things, and I think those boxes in the middle, although that's really important for learning action planning, I think, yeah, it wasn't used as much. And then the SMART thing in the pre-work, there's nothing to guide them into a SMART plan. Just they're not all that familiar. They might know SMART, but they wouldn't write it out in a SMART way.
Oh, okay. Okay. Thanks, Margie, for that feedback. I think, too, what we'll talk about, so we're going to talk about the new format for small group learning sessions next week. And the small group learning sessions have a slightly different action plan template that we're trying out with those ones. So I haven't actually seen it, but it might be something that'll work better instead of this. So that feedback is great, and if you, it would be great to see an example of that too, Margie. So if you have one where you can, go ahead and block out the physician's name and any of that stuff if you want to. And if you could send it to me, and I'd be curious to have a peek at that too. Would be great.
Yeah, so that was the other thing, and we used to have action plans that were on triplicates. Then I could have a copy of it. This particular one doesn't have that. So one of the things that I regretted, which I'll try to do afterwards or next time, is take photos of each one or something, because I don't really have their copies.
Ah, gotcha. Okay, that's a great idea. The other thing too, and I was talking about this with, I'm sorry, I can't remember who at Fraser is, but Fraser does carbon copies with their printer. So I don't know if anybody else is doing that, but that might be something that sort of your central group could do. So maybe we could talk to, for you guys in the north, we can talk to Candace and Pam about, and whoever moves into Denise's role, about, sending out carbon copy forms that you could use instead, if that would work. Maybe taking pictures.
Actually, that came up yesterday when we were talking about the small group learning session action planning piece, which also, just by the way, includes information about how to create a SMART goal, which builds on the QI 101 and 102 small group learning session material. So it's nice to hear that feedback, and maybe we're going in the right direction. But that whole idea of having a triplicate is something we should definitely consider once we get the format of the action plan nailed down.
The other thing that they asked me is, what do I have to do? Just tell me what I have to do and I'll put it on here. And so that's the action period work. They kind of like the idea of a checkbox, These are the things that I want to do, and then they meet in their little huddled group to decide exactly how that's going to work in a SMART plan, but they need to see in front of them what is expected in the action period. So you have in the COPD, I think COPD and maybe some of the other modules where you have an action planning template form where they can check off what's required of them. So I actually almost use that, but use this version, and this version works better, but they still need to see exactly what is expected because they're going to do that so they get paid, right?
Yeah, I think that's a hard piece with the sort of the individual, when it gets into the more in-practice support and it's not framed in a specific module and in a specific topic, because what they're going to need to do is going to be different for every practice, right? It's not necessarily something that's standard across the board. So that's something it's a little more difficult with those pieces because we don't really have defined tasks for what they need to do to get to a certain point with one of the attributes, for example. Yeah, it's a bit of a harder space. But I think too, if you're sitting down with them and, you know, they know what they want to do, then you can work backwards from that and think about, okay, well, what, you know, together let's figure out, or let's sit down with the MOAs or the other docs in the practice and figure out what it is we need to do to actually get there. And let's list those off, and then we can check them off as we go.
Yeah, that's what I ended up doing, and I think just having it really clearly defined in a slide or something for those who present, these are your choices, or anything else in the spirit of motivational interviewing, or anything else you want to do.
Yeah. Yeah, for sure.
Hi, this is Joe. So I'm just looking at the action plan. So basically the process and wondering the process. So if they're choosing not to have RST support, which is their choice, which is fine, they're going to complete this. They're going to submit it to us. If we deem it incomplete for payment, that's when we actually say, you know, we'd like to meet with you or whatever. You know, there's a few things missing here or whatever, the nice wording that we have to use in order to get ourselves into their practice. So is it up to us to decide, to determine that it's incomplete, or are they going to send it, like, I'm still, as per the process, they are submitting it to their RST team in order for the seal of approval that they've completed and they've done an action correctly?
Yeah. Yeah. So there's still, like, it will be clear in the communications around compensation and everything that they are expected to document attempted change in their practice. So it's the same kind of expectation around the module work. They need to document on an action plan that they have attempted something in their practice. It's just less, it's more broad and less defined than it is with the modules, because the modules are clear-cut, have clear-cut expectations. Right.
It's Rob here from Interior. Can you hear me?
Yes.
Great. A bit of silence there, so I might as well ask a question. I think you mentioned, so I'm just trying to get this straight from a initiative level. So this is our PSP tool that we've developed for practice level assessment, but we recognize that there may be other divisions that have a tool as well. And then you mentioned there's a larger initiative as well that might have a tool as well that the GPSC group will link with. So just so we know, like, if we're working with a clinic, there could be 3 different tools that they're looking at, right? Is that the case?
So our plan is definitely not for them to be looking at multiple different things, but sort of some of the divisions do have their own agenda around surveys and what they're using for that, and some have definitely moved forward. So there will be some places where the division has their own tool that they're using, but it's, you know, nobody's going to make a physician do any one tool, so it's up to them what they want to do, and if they decide they want to do 3 different things, that's, you know,
so from a strategic standpoint, if the divisions have a tool, then we probably want to work with them on that tool and not do ours? Is that what we're saying?
No, I'm saying it's up to the physician in the region what tool they want to use, and we are working, and GPSC is working with the divisions to work towards something more standardized across the province. So ours is like GPSC endorsed this tool to be used in the practice.
Okay, great. And that's the next question was, some of these questions are, someone talked earlier about practice level and network level and system level or community level. And some of these questions are really system level type things. So, and some of them are the exact opposite. They're just right in the practice, so the practice has a chance to make a change if they want. Have the health authorities reviewed this for potential impacts on some of these questions? So I know that they can get a little bit, like if there's questions about, for instance, the follow-up by primary care practice with patients seen in the emerge department. So the low end is that generally it doesn't occur. There's no follow-up because the information is not available to the primary care team. And the high end is that it's done routinely because primary care practice has arrangements in place with the ED in the hospital to track these patients. So you're talking about a system change there that would be a major initiative if it was to actually move towards the good end of that scale. And maybe those are system level questions that could be developed by the larger initiative, and we just stick to the practice level questions. There's about 6 or 7 of them on there that are really sort of system based.
Yeah. Hi, Rob. It's Lucas. So I think you raised a really good question, and I think that inevitably in looking at an assessment at the practice level, there's implications for system level either gaps or required change or so I think that part of what this tool might be able to do is help to shed light on some of the system level or community level implications as well.
So if the system wants that light shed on it, then this is a great tool. But if it doesn't, then I would highly recommend that they review it first before this is done, because they do not want to be taken by surprise by these types of things, right? So again, identifying the gaps, if they want those gaps identified so they can work with the larger primary care home initiative and say, okay, so we don't talk well with the ED, what are we going to do? Let's figure it out. Like that's great, but just make sure that that's where they're at.
Yeah, that's a good
Thing
point.
on here on surgery, on surgical access as well. So that's the type of thing, right?
That's a good point, and I don't think we're at this point worried about those people, those stakeholders not putting an eye on this, because there is a lot of interest from all the stakeholders we're working with on being able to take a look at the tool, whether it's through that working group that's been mentioned a few times, or more one-on-one and indirect channels. But there's a lot of interest in this tool, so I think that review is going to take place.
Great.
Hi, it's Renata calling. I just had a question about the actual scoring. I noticed that you had levels A to D, and then underneath that you had, within level D, for instance, you have scores from 1 to 3. Can you speak a bit more about how this tool is going to be scored? Who's going to do the actual scoring? Can you please tell us?
So if I understand your question right, you're asking about how does someone respond along the scale. There's sort of levels and then numbers within levels. So the idea is that the levels and the text associated with the levels, so when it says, 24/7 access is provided through, and then level A is referrals to walk-in clinics or something like that, those are anchors along the scale. So those anchors are supposed to help the physician determine where on that 1 to 12 scale they feel they are at. So 12 obviously being sort of the highest achievement of the attribute or the practice characteristic, and 1 being the lowest. So does that make sense? The levels are anchors to give an indication of what it means to progress along the scale?
The levels make sense, but the numbers at the bottom still is not quite clear to me, because in my, from what I understand, if something is not done, it's not done. So there's no 1, 2, 3. If we're not doing it, we're not doing it. So I don't understand the meaning of the 1, 2, and 3.
Okay. So I know in some of the other tools, there was different approaches to guiding people through that. But that's, and I think, so that's a good point, and I think that that's sort of, we're really keen to hear from physicians and from you as you go through this experience with them, those kinds of issues. So if that's something that's coming up, we want to hear about it.
I think we can put a little more guidance in the guidelines document around sort of the approach with physicians and how, how that could work and how you could present that to them as well.
Thanks for that comment.
Other questions? Okay. All right. So I think because we only have a few minutes left, it's not really enough time to dive into any questions or comments around the EMR functionality or the panel assessment. So if you do have anything you want to bring up about that, please don't hesitate to email me or Christina and it will get to me. Or, as always, you can reach out to Candace or Ranjit, or sorry, not Ranjit, Ronnie, with VCH around the EMR functionality. What I do want to say before we finish off here and log off is that even though there are options for physicians to do some of this work without us, we offer such a unique service and support to them. And it's such a huge value add to their practice to have you guys in there and supporting them and working through these things with them. And no one else in the province offers that, and they don't, or even when they do have some support coming from somewhere else, there's not sort of the payment incentives around it. They don't have the same skill set necessarily as you guys have. So we have a really, really unique program and service that's out there, and they should be knocking down our doors to ask for you to be in there. So, we think that this is really, the work that you do is really important, and it's hugely, hugely valuable. So please don't, look at those options and think that we're thinking anything negative about the work you do or anything like that. Like I'm concerned that you guys are sort of standing on a ledge and thinking, well, geez, they don't need me, they don't want me, and that's totally not true. Like, you are integral to this work. So, please back away from the ledge. All right. Okay, if there is nothing else, then I will be sending, or Christina will send, a copy of the recording, updated guidelines, further clarifications around the compensation pieces, and sort of how the tool can be filled out. And we will talk again next week with Mallory, who's going to take us through the new SGLS manual, and we will just about be ready to roll with small group learning sessions again. Thanks so much, guys.
Lydia, before you go, can you make sure when you do the compensation update, can you add what the MOAs get paid? I don't think it was on that slide.
It wasn't on the slide. I will add it in. Thank you.
Okay, great.
Thanks, guys. Have a great day.
Thanks. Bye.